Good afternoon and good morning. Welcome to our webinar from HealthRecon Connect for the future of lab reimbursement, what happens now that PHE is over. During this information webinar, we will explore such topics as the reimbursement for high throughput technology, PCR and Antigen COVID-19 testing codes and reimbursement, changes to specimen collection codes, prior authorization waivers, Medicaid reimbursement after the end of PHE, necessary steps for Medicaid credentialing, plus how does California's SB 510 impact labs and their operations. It is an honor for me to present our guest speakers, William Baus, who is the Director of Laboratory Services, Brett Walker, who is our owner, and also our Chief Client Services Officer, and Dean Viskovich. And I'm going to give you a little bio of Dean since he is a non-HR employee. Dean was admitted to the bar in both New York and Florida with over 25 years of experience as a trial attorney on behalf of insurance companies and healthcare providers, with emphasis on laboratory compliance and revenue cycle management issues related to the healthcare sector. He was formerly Chief Compliance Officer and in-house corporate attorney for the publicly traded and privately owned healthcare entities in Florida and Texas, trial attorney for Royal Insurance Company and Nationwide Insurance before entering private practice to represent healthcare providers in litigation against insurance companies. Dean has significant experience in litigation of claims for healthcare providers and individuals, as well as expertise in liability, related matters and compliance-related advisory activities on behalf of healthcare providers, focusing in laboratory and revenue cycle management. His areas of emphasis include OIG compliance, diagnostic laboratory testing, NGS, PGX, clinical infectious disease, toxicology, laboratory information services, CLIA, COLA, CAP, comprehensive coding, ICD.
Wow.
Yes, medical billing, CPT, and HCPC codes, and financial services for the revenue cycle management. During the course of this webinar, it is an open forum. Please feel free to raise your hand or type me a message, and I will call on you so you can ask the panelists questions. If you have anything else you'd like to say, or whether it's asking or your opinion, please feel free to do that. At the end of this webinar, please fill out a short survey that we will be sending you. Within a couple of days, you will be getting a recording of this webinar. If you'd like to have additional information, let us know, or if you'd like to set up time with any of the panelists, please let me know, and we will go from there. My name is Linda Protopappas. I'm the Executive Vice President of Sales, and with this, William, it's all up to you, sir.
All right, welcome everybody. Brett, I remember you thinking maybe you wanted to set the space over the agenda.
We'll kick it off since you two guys are the real experts, and we'll do a lot of the discussion here, William and Dean. So everybody, thank you for meeting with us today. We're going to walk through kind of the impact post the PHE to Medicare, Medicaid, commercial plans, what the California rules are, and then overall ID testing and where Z codes are. If we give a summary of this, the biggest impact that we'll share is that some, COVID obviously as a test, as a vaccine, as treatment will obviously continue post the PHE, but a lot of the rules around the PHE, especially without a network coverage and patient co-share, will be changing with nuances per plan. So we want to walk you through those, get you that information, make sure you understand it, allow you some time to ask questions, and then talk a little bit about the future of where this goes. So with that, William, I'll kick it back to you.
Excellent. All right, so we're going to start with Medicare first. So the protected health emergency ended on May 11th, 2023, this year, just a little while ago. COVID testing, cost sharing, and provider ordering requirements. So of course, this was Medicare, and as far as diagnostic testing goes, it's covered at 100% for Medicare beneficiaries. So before and after PHE, we didn't have any cost sharing with patients anyways. And so of course, physician signature requirements, at the very, very beginning of this, they said, yeah, you don't need a signature. And then a couple months into it, they were like, well, I guess we do really need to have signatures if y'all are going to get tested this often. So after the first one, you did need a physician signature. And of course, you needed the right diagnostic code. That changed on us over time, but we're not here to rehash the whole thing, but things changed over time. And so that made things difficult for us. But certainly after the PHE, we've got physician signatures. And then, Dean and I love to have this conversation about, do we need physician signatures or not? And what are the real rules about that? And I think it's important maybe to just take a moment in time here for that. Dean, what do you got top of mind on that?
Yeah. Hi, guys. Thank you so much for the introduction. Very kind. The bottom line is, initially during the PHE, you didn't need the physician signature and the according documentation that goes along with it. After a while, they said, you're going to get the first bite of the apple for free. And after that, you're going to have to comply with the signature and the documentation requirements for subsequent COVID testing. When we talk about a physician signature, to me, the gold standard is the ordering physician signature on a manual requisition form or electronically. However, CMS does allow for an order to be considered medically necessary if it's clearly documented in the ordering provider's EMR, i.e. his progress notes or his daily records. If on this data service for this specific patient, you have the EMR records where that doctor specifically ordered that certain laboratory test, then it can be deemed medically necessary and reimbursable without the signature. The concern is the relationship that the labs have with those ordering providers and obtaining those EMR records, because for the most part, labs only have a requisition form and a final report, and those two documents by themselves do not substantiate medical necessity as far as CMS and the third-party providers are concerned. They want the documentation from the ordering provider as well. So that's important. If the ordering provider's documents do have specifically state a lab test, you're going to be okay. But if we should err on the side of caution, an electronic or manual signature is always my preference.
Excellent. And I often get a question too about, well, do we really need patient signatures? And well, you're going to have a problem with the assignment of benefits, and say United asks for medical record review, and you don't have a signature. Well, now you can't even appeal because the assignment of benefits has not been done. You could still go back and get it later, but all of these things are a bigger part of an OIG compliance plan. And again, that's something Dean does day in and day out. And there are many, many details that we couldn't get into here. But if you're moving forward and you're getting out of COVID into other stuff, I recommend you get an OIG compliance plan for your lab together. And it incorporates.
Some of the third-party carriers are going to request, if you want to get network, that you show proof of an OIG comprehensive compliance plan. So that's obviously an economic motivator. When we talk about the patient signature, a lab requisition form is analogous to a prescription when you go to the pharmacy. If it's not signed by the ordering provider and you bring that script to the pharmacy, it's not going to get filled out. When you bring a rec form that's not signed by a provider, the lab shouldn't run it as well. The patient signature is not required to run the lab test. However, the patient signature is usually good for patient consent. You don't want a patient to say, hey, I didn't agree to order this test. Number one, I didn't agree to the patient financial responsibility. Number two, or number three, we do have that assignment of benefits language in that direction to pay, where you'd prefer to have the lab stand in the shoes of the insured in order to make a claim against the carrier for a reduction or a non-payment.
So then we get into vaccinations, which, it's actually a good thing for labs. There's a lot of labs that if you focus in on SNFs, you should definitely look into incorporating mass immunizations for flu and now COVID. It's hard enough to figure out how to make money with a SNF, and this is something that can get you some more money. From a physician perspective, we're looking at $40 for the administration through the end of 2023, expected to be $30 next year now. Now, as of July 1st, SNFs are going to be billing the vaccine administration to Part A for their Part A patients. So up until then, they had been able to get paid for that even when a patient was on Part A. And a little background here in case if you're not 100% familiar with all of this. So SNFs are skilled nursing facilities, which are different than an assisted living facility, or if you say the word nursing home, you could mean a SNF, but you could mean something that's not a SNF, but is a facility. So we can kind of lump them all together. If anybody is on Part A benefits, and we're talking about Medicare here, but the concept kind of works like this. So you got Part A, that's facility stuff. That's when you're in a hospital or a SNF or a facility. Part B is fee for service. That's what we as labs can be paid for. And then there's C and D, pharmacy benefits, and then your Medicare gap pay and Medicare. What's the
Managed plans, Part C.
Yeah, I couldn't think of the word. And so the biggest thing to understand is when you've got a Part A patient, you're not going to get paid for that. You need to be billing the SNF directly for that. And yeah, you should already have that in place before you decide to take on SNF business, because it might be a real surprise to you, but not all the patients are on Part B, right? Most of them are on Part A. So you got to get that straight. So,
yeah, William, if I could jump in,
yeah.
And that's the key here. The whole thing comes into bundled payments with Part A, i.e., they're getting a reimbursed from the carrier for all the services that are provided during a period of time. It's usually 30 days or so, and that includes the diagnostic and the lab testing, and including the vaccinations. So the lab kind of has to chase the facility and not the patient to get paid, because that's all included in the bundle. So you just need to be aware of that.
Yep. And then in relationship to this, as the third party would bill the SNF when they're on Part A, like we already said, and then there is no out of pocket because this is Medicare for Part A or B patients, right? Now we get to pharmacy. Oh, this was so fun when this was all going on. So the biggest thing to understand is Medicare does not think pharmacists are physicians. So in general, they can't order anything. And so before PHE, no. And after PHE, no, they can't order tests, right? Now, there is a big movement by pharmacists to keep pushing for Medicare, and they've been doing it for many years. But at the moment, this is how it would work. A pharmacy can have a lab. So they can get a CLIA, they can have a lab, and they can sell, they could have a CLIA waiver and sell CLIA waive tests, right? They could have a certain level of a CLIA, like a moderate, high complexity, and do PCR testing. Now, during the PHE, they could also order the test, right? But now they can't. But that doesn't mean that the whole part about them having a CLIA or not goes away, right? So the way a pharmacist can be paid for Part B services is if they're billing incident to the services of an enrolled Medicare provider. And that basically means the doctor, she's overlooking the pharmacy, and then you kind of are billing under her license. And then in that manner, you can do lots of really neat things, like the pharmacist could analyze a PGX test result, or talk about coordinating the patient's medication therapy and manage that for under the auspices of a doctor. All of those interesting topics are something to take a look at as a lab, and it is a lot of progression of labs looking at incorporating pharmacy in their lineup of testing services.
Yeah, that's huge. The connection between pharmacy and labs it's something that William and I talk about a lot with clients, and the potential to be more proactive than reactive. But the bottom line is it was an all hands on deck approach during the PHE, and they broadened ordering providers to include pharmacies, and that's going away. And if a pharmacy wants to order those lab tests, they're going to have, you can have a CLIA license, you could become a lab. You're going to need to have some type of ordering provider or a clinician, whether it's an NP or a PA, that could do the ordering that the pharmacist is no longer going to be allowed to do now that the PHE is over.
Excellent. All right, let's get into some specifics with Medicare. So we did have a document that introduced to us the U codes, the 1, 2, 3, 4, and 5, that would have added up to either, if you weren't using a high throughput technology, the U codes for 001 and 002, the high throughput technology for 3 and 4, one being the the CDC version, or the other one being just an LDT. Those were worth $75. And then you got your extra $25 because you got them done within 48 hours from the date and timestamp of the order to the date and timestamp of the result. And as long as you did 51% or greater of your tests within that 48 hours, you were able to continue billing for the extra $25. And but if you were under it, you were supposed to wait another month until you had actually gotten it up. They are doing audits on that, by the way. You will get them checking up on you. So you do probably want to maintain those records that you can prove that, well, the order was this time and the result was at this time, and that we did that better than 51% of what we did in that month, right? Some kind of a report like that would be good. So the code you're going to want to use now is your standard American Medical Association CPT code for COVID testing, which is 87635, which is $51.31. And as far as Medicare goes, you don't have to worry about it going to deductible. I probably should have put in some of the other codes. There's some things that if you guys are interested in, there is a genotyping code now for about $300 for COVID testing. And that's kind of an interesting thing. But of course, the patient would have needed to be positive for COVID, and you would need to be working with a provider that's going to take that information and then actually do something with it. There must be a change in treatment, right? They don't pay for tests for nothing to be done, right? This isn't some add-on test. But if your providers are doing long-term COVID or are providing information about the selection of a monoclonal antibody or something like that, well, then that makes sense. And we do, as laboratories, need to understand that as far as the OIG is concerned, we are responsible for helping guide the utilization of our tests with the referring physicians. Of course, also the COVID collection codes, the G2023 and the G2024 that you got $2 more for, because everything's worth $2 more when you do it with a SNF. And then the over-the-counter testing, also known as OTC, the K code, K1034. Medicare will not be reimbursing that after the PHE. The dates of service that are related to that are the date of the order. You didn't need to have a physician signature. You didn't need to have a diagnostic code. If you didn't have one, they told you just to put in suspected exposure. But your primary payer for this is Medicare, and we'll talk about it from a commercial perspective and Medicare perspective later. Your antigen and your antibody testing, your titer screens, those kind of things, there's no changes in their coding. Again, you won't have any patient responsibility. Brett,
yeah, William is spot on with respect to PCR. The bottom line is it's going down from $100 to 51. So it's getting literally cut in half going forward, and it's going to have to be diagnostic, which means you're going to have to use it to diagnose or treat, and you're going to have everything that you did prior with respect to medical necessity and documentation and ordering physician's signature. Same thing, the COVID collection is gone by the boards as well. And the over-the-counter K1034, which a lot of labs have done very well in since January or March of 2022, that is also has gone away as of 5/11/2023. I know in March of 22, the CMS allowed the over-the-counter for Medicare beneficiaries that was it 8 tests a month at $12 each. That was reimbursable without any cost share. The same went in effect back in January of 2022 for group health plans. the same 12 and 8, but that's gone by the boards. What hasn't gone by the boards for the over-the-counter for the without cost share is basically Medicaid. And then we'll talk about California. California is the outlier, not only for diagnostic, but screening going forward. So if you're doing, if you're seeking reimbursement for Medicaid, make sure you're credentialed with Medicaid in the state that you're obtaining the specimens from. And the same thing, if you're obtaining specimens that originate from California, make sure your lab has a California out-of-state lab license. That's very easy to overlook.
Yep. And then, not that we have time to get into it in a deep way here, but Dean has had a couple of clients that have had a little bit of trouble with Medicare, wondering why the OTC was delivered to a patient that's no longer alive. So I think if you are having any difficulties like that, maybe trusting where you're getting your samples from, you might want to start looking at that now, because this will be looked at by Medicare deeply
Audits,
in the time to come.
That's always the concern, because the whole over-the-counter thing has been through a vendor who's got a management agreement that's providing the Medicare documentation that supports consent. The labs are relying on a third-party entity, and the concern is the lab has the relationship and is submitting the reimbursement through the third-party billing company to get reimbursed from CMS, and those third-party vendors don't have that contractual arrangement, and the request for overpayments for audits and documentation is between the payer and the lab, and not the vendor who the lab is relying on. So sometimes you just have to be very careful in that three-part relationship between the payer, the lab, and the vendor that's doing the obtaining that Medicare beneficiary consent.
Oh, my favorite, Medicaid. Okay, brief overview on Medicaid. Okay, so every state has its own state Medicaid program, and then usually within a very quick period of time, many of the Medicaid patients get moved to what we normally call a managed care organization, which is really a third-party administrator, in much the same way that the Medicare MACs are, right? Like those are private companies that do it for the CMS, right? Well, Medicaid does the same thing. So not only do you have 50 different Medicaids, but you've also got, well, between 5 and 25 sub-Medicaid plans that if you're not credentialed with under before PHE and after PHE and after their extension, which we'll get into in a minute, you would need to be credentialed with them to get paid. So that's just to kind of set the stage that Medicaid isn't just Medicaid, and it is difficult. And if you think about credentialing with Medicaid, first get your home state. Before you get your home state, you're going to have to get your Medicare. So you get your Medicare, then you get your home state Medicaid. Then you can start talking about out-of-state Medicaids. But what I would do if I was a lab is I would focus on getting my home state Medicaid and working on getting doctors to help, say how great of a lab I was, so I could get in with the sub-Medicaid plans in my home state and then work out from there, right? All right, that being said.
I agree with William, and bottom line is the states have basically outsourced Medicaid to the carriers, and now each carrier has a Medicaid, like they have an HMO or a PPO, and it's basically regional. So you're going to have to get in with the Medicaids in the regions that you want to do business with. There's a lot of hoops that you have to jump through. Obviously for Medicare, you need to get your PTAN. For Medicaid, you need to be credentialed. And a lot of the Medicaids are going to say, which is odd to me, that they want to see that you are providing services to Medicaid beneficiaries and literally submitting claims that are getting rejected because you don't have a Medicaid credential in that state before they will even consider processing your Medicaid credentialing application. I see Brett shaking his head on that one, and I always found that one a little odd. Like, You mean you just want me to run these where I know I'm not going to get paid because because I'm not credentialed? The whole cart before the horse thing, and I'll let Brett jump in on that, but it's always confusing to me.
Yeah, Dean, you're right. And, I want to say a few things. I mean, in the situation, what's really going to be the biggest impact here is after the PHE, which ended last Thursday, the credentialing requirements, apply. So as we've talked about, these Medicaid managed care plans that you're not in network with, if you're not, will, even though the service is covered through September 30th of 2024, you're not in network with them if your doctor's not in network with them. And so these Medicaid plans have been really strict. And remember, Medicaid is a social welfare program. It's not an insurance company. Where Medicare is an insurance company, Medicaid is not. It's part of the Title 1819 Social Security Act that was long time ago. And because of that, it's state run, there's always been difficulty for labs to get paid by out of network Medicaid managed care plans, even if they are a traditional Medicaid provider in that state. And this is something that we could have a whole nother discussion on, and maybe William Dean at some point we do, because in the Medicare Advantage world, you are able to, fight with the payers. It might take you several months and say, but I have a Medicare provider pay me. In the Medicaid world, because it's not governed necessarily by the insurance commissions as a welfare program, it's a little different. But I think the biggest thing from the PHE is to remember, just because Medicaid, it was great news. We had several of our clients call us and go, you mean I can still do Medicaid through September 30th of 2024? I said, traditional Medicaid, yes, if you're in network, but the managed Medicaids, you have to be in network with, or they're going to operate just like they always have. And William, I'll kick it back to you.
Thanks, Brett.
So, yeah, I mean, we've got COVID testing, cost sharing. We're going to have that covered for diagnostic testing for Medicaid patients. And when I use the word diagnostic testing, I'm using it the way the payers mean it. I mean, to the lay person or anybody in a lab, I do testing, which is diagnostic. So it's all diagnostic testing. What they really meant when they used the term diagnostic testing is that it's being ordered by a medical professional, and there are indications for the reason why it's being ordered, and there's something we can do about it after we get the result back, right? That's what they mean when they see diagnostic testing. So of course, you need diagnostic codes, you need a provider ordering it, and then it will be covered at 100%. And I think most Medicaids have really low deductibles anyway, so it's like, thanks so much for that, right? But anything helps, right? And then, that's going to work through September 30th. And then, of course, you need your physician signature, medical necessity, and then all of the, anything that you're out of network. If you're not credentialed with these sub MCO plans, they're just not going to pay you just the way they always did, right? So, Dean, any?
No, that horse we beat it pretty well.
We took care of that one, right?
Put that one to bed. All right, and then all of our reporting requirements to the CDC and the Medicare and all this stuff. I'm not talking about PAMA. I mean about COVID testing, right? Those went away, and I think PAMA got extended. I don't know. Sorry to put you on the spot there, Brett. Do you remember when PAMA is extended to? It's like another year or something. It's 24.
No, it's another year because it's still not done. I mean, COVID played a part of that. Some new molecular testing played a part of that, but what PAMA was supposed to do in reducing costs with labs has not occurred. And we all know in this country right now that we don't even know in a week if we're going to have money to pay the bills. So, this is under a lot of scrutiny, and they did extend the PAMA cuts and the restrictions, and those will continue, which I know is not great news to labs or diagnostic companies.
Right.
William, I don't have the exact date. Sorry, I wish I did.
Right, I didn't. I just popped it in my
It's all
head.
right. You threw one at me, yeah.
And then
hey, William, one thing I wanted to jump back on the Medicare was with respect to the website and that posting price and the transparency that we forgot. I've got a lot of lab clients saying, hey, does that still apply? And the answer is no. It ended with the end of the public health emergency, and basically what they said, in accordance with the CARES Act, that the special price transparency requirement will terminate. Price transparency requirements under other laws and regulations will continue to apply, but that specific, posted on my website price, if we don't have an agreed negotiated price, you've got to pay my website price. And a lot of times that's a multiple of the clinical lab fee schedule. There was a lot of infighting, a lot of complaints from third-party payers regarding that. That's over, and the carriers, I'm sure, are thrilled about
it. Yeah. Do you think there's any chance for, for dates of service that were there and we can prove that we had posted our price?
Sure.
If there's anything that could be done about that, like from a legal perspective, maybe?
There's no doubt that, once we have, if the claim has been either basically rejected or denial, or a lot of times it's going to be reduced, where they're going to pay you, say they're going to pay you $100, 100% of the clinical lab fee schedule for that PCR test. Okay, sure. And then you say, hey, my posted website price during the PHE was $250. I've seen a lot of guys go to the mat over that and be successful, as long as you jump through all the hoops correctly. Okay.
Yeah.
And that you've got the documentation after the first COVID test and stuff like that. So like anything, you either negotiate from strength or weakness as a lawyer when you're dealing with these carriers. So the better job that you did, if you had that documentation, you'll have your lawyer or your compliance people look at it. And then, they can make a business decision. Yeah, we can go to the mat over this stuff because I can prove it. Basically, going into the court of law, you're gonna have to prove everything by the greater weight of the credible evidence, i.e., over 50%. So that's huge. And certainly this issue has been ripe with litigation. And this issue, I mean, the posted website price where you've got, a reduced reimbursement rate. Make sense?
Absolutely. And then just to reiterate, there's, you're going to need to be credentialed with a Medicaid to get paid. And it's not just being credentialed in your state, right? It's the actual plan that the patient has that you probably don't know, right? Because your referring physician has told you they're on Medicaid, but they moved to another superior plan 12 days ago, and now they're on superior and you don't know, right? So Medicaids can be tricky. The better you give the information, though, the better the source is actually accurate of who they have as insurance. Really helps out your billing company. All right. I'm going to come back to this one. Let's do commercial, and then we'll come back to additional things that I thought would be very interesting that are after the PHE, because also it's after this amount of time, right?
William, before you start the next slide, I do have a question from Walt Cooper, just making sure he understands on COVID reporting. Is it no longer required to the DOH for any COVID results?
It is my understanding that is no longer a requirement. Dean, do you have any specific
that's my understanding as well. You could look at, William, I think that we've got some CMS documentation that we could provide to the attendees, and they've got a FAQ and things that like that. And I know one of the issues that we have spoken previously about was the reporting requirements that have been basically revised.
Got it. Yeah, we'll send you guys. There are
we'll send them a link.
Documents that we were referring to get the exact dates and exactly this or that going on. The most complicated one we haven't gotten to yet, but that'll be California. Go figure, right? All right, so Medicaid, much like Medicare, right? So our high throughput U codes are gone. Our code to use will be the regular AMA code for COVID, $51 according to Medicare, but Medicaids are probably going to be less than that. Usually like 20% or more or less, right, Brett?
Yes, typically 60% of Medicare.
Yeah. So then COVID collection codes definitely retired. We'll get into travel reimbursement for what's happening for us that we can still get reimbursed for later. The over-the-counter testing, the expectation is you're not going to get reimbursed for it, but the way that they've written it would indicate that they are supposed to cover it. But I've had trouble getting paid from Medicaids for OTC, or in truth, also even with PCR, there were lots of hassles about what the fee schedule was, or whether they had to pay you or not, or whether you were credentialed or not. If you're going to look at doing this with the Medicaids, it does seem to indicate that they should pay for it.
Yeah, William, I'm going to jump in there. And we have specific guidance from CMS that says generally as a result of the American Rescue Plan, states must provide Medicaid and CHIP coverage without cost sharing for COVID-19 vaccination testing and treatment and treatments through the last day of the first calendar quarter that begins 1 year after the last day of the COVID PHE, i.e. when it ended on May 11th, 2023. This coverage requirement will end on September 30th of 2024. So that's how we got this date. It's the last day of the first calendar quarter that begins 1 year after the PHE ended. So it specifically says that vaccinations, testing, and treatment for Medicaid should continue without cost share until September 30th of 2024. Whether they, and that's out there. So if you get those denials and rejections, these are the types of things in the documentation that you have from CMS that you need to rely on and form the basis of your appeal.
Excellent. And then commercial plans. So COVID testing cost sharing, provider ordering requirements, diagnostic testing will be paid for and will have patient responsibility. Now let's just drill that home there. So return to work, return to school, travel and entertainment was not considered diagnostic testing because it was not related to the condition of the patient. It was a condition of access to facility resources, which is not a covered health benefit.
Yeah, it's screening and not diagnostic as as the general category that we could throw all that stuff in.
Right. And in general,
unless you're in California, you get paid for diagnostic and screening.
Yeah, yeah. And in general, with any payer, the word screening is basically not a good word for you to be using as the testing that you're doing, unless it's actually something they explicitly cover. Like there's only one genetic test that's covered by Medicare that's called a screening diagnostic molecular test, right? It's the Colonoscope, right? Anything else that they're talking about, like, breast cancer screenings, they're talking about mammograms, not genetic tests that they pay $5,000 for, right?
Correct.
So you better have a reason for whatever test you're doing, for anything you're doing, right? And yeah, let's have the physician signature and let's have the right diagnostic codes. And yeah, in and out of network requirements apply. There's something I want to address that it comes up so often. I think it would be useful information to people. Because you are in network versus out of network, that doesn't determine whether or not a payer thinks something is experimental and investigational. So it's not like, being in network is going to get me paid for tests that payer doesn't normally pay an out of network person, right? If a test is something that they think is a covered benefit for their patient, and the patient has out of network benefits, and this is the real thing here, then they're going to pay for it, right? But what you get paid for it, the dollar amount that you receive in your bank account will be different. And it's because in network, you've agreed to a contracted rate, which is typically lower than what they will consider usual and customary, which is what you get paid when you're out of network. But alternatively, I'm going to have twice the amount of deductible and twice the amount of coinsurance. And usually you don't get twice the amount of the allowable. So all things being equal, it's going to be better for you to be in network, although it's not easy to do that. And that's another whole topic, right? But anyways, that's what in network.
Yeah.
Network
the overview, when we talk about, coverage and plans, you're talking about HMOs and PPOs. HMOs don't have an out of network allowable. You have to be in network. If you're not in network, you're not going to get reimbursed for those services. The PPOs have an out of network requirement that basically there's more patient financial responsibility, but it gives you the a choice to go out of network to have those services provided. It's basically policy specific. You have to look at the language, but generally HMOs do not provide out of network benefits, and that's why it's a cheaper premium. versus the PPO that allows the patient to have a little more wiggle room, but that comes with the requirement to have an increased patient financial responsibility.
And then Medicare is retiring the codes, the U codes, those are Medicare codes. So the understanding is commercially, they're not going to be paying for those codes anymore. They may take some time to implement or not implement that they do or don't pay for those. And maybe they continue to pay for them for a little while, but then they're going to ask you for the money back. And then you're going to have to go back and bill it again as another code. So I would just pay attention that it's done. You've got an 87635, you bill that, that's what you're going to get paid. The G codes, you know, that's an interesting thing too from these codes. These collection codes were confusing because Medicare was really specific about how they were to be used in exactly the same manner that phlebotomy blood collection codes are done, right? And that is, it's for a homebound patient as defined. That's a medical term. Doesn't mean you're trapped in a bed. Brett's got a good spiel on this as well. You want to say it, Brett, or you want to?
Well, yeah, I mean, Medicare's definition of homebound is you're unable to stand, sit, or walk without assistance. It doesn't mean that, so you're not going to get in and drive yourself around, necessarily. You're not going to be, you're people with a walker or a cane or need help getting up. It's not that you are bed confined. And a lot of people, bed confined means you're in a bed and that's it. And someone's basically taking care of you. And a lot of people confuse sometimes homebound with bed confined, but homebound is unable to sit, stand, or walk without assistance as defined by Medicare.
And that's still good knowledge for you to have because that works for your phlebotomy code, which we will address here shortly. And what I was trying to point out with this whole thing about commercial plans is they didn't care. What you were supposed to do was not pay per sample, which would have been a violation of ECRA when you were getting samples from 10 people. The people that were there at that tent should have been billing an E&M code 99211 and getting their roughly $20 to $25 that they would have gotten for a low level existing patient, even though it might have been a new patient code, right? And so the commercial plans were like, well, if you're stupid enough to bill a G code, which it clearly said you were not supposed to be doing unless it was a lab tech professional on site collecting on behalf of a home health agency or at a SNF, right? If you weren't doing that and you wanted to take the lower dollar amount G code, then they were happy to pay you. But then eventually the commercial plans weren't going to pay for both a G code and an E&M visit code. So it caused a lot of confusion with people. But regardless, it's over. You're not going to get paid for collecting samples. And no, they don't pay commercial plans. I mean, all of them I know do not pay for you collecting a blood sample for doing blood testing either, right?
Very little. Yeah. It's really rare.
And then over the counter, already during the PHE, I couldn't get Aetna to pay for the life of me a consistent dollar amount for an OTC. Some of them were paying, some of them weren't. They can continue to cover it. The ones that were, maybe they'll continue to cover it as they go forward. But I would consider it dead.
Commercial carriers are thrilled that the PHE is over. They hate the whole waiver of cost share for patients. Over the counter is over the counter. When you go to Walgreens or CVS and you buy your Advil, your insurance company's not paying for it. When you buy the over-the-counter pregnancy test, home pay, any type of test like that, for the most part, your insurance companies aren't paying for that. And they're going to lump the over-the-counter COVID test in the same thing. We're not paying for it. There may be a transition period between now and the end of the year, maybe later. It's going to be plan specific. You're going to have to see what your carrier is to see how generous they're going to be. But usually I don't put generosity and third-party payers in the same sentence. It's like jumbo shrimp. It's like mutually exclusive. It just doesn't go together.
Oxymoronic.
Very oxymoronic. Exactly.
All right, so let's talk a little bit about California, William. You threw it up here, and as you guys have mentioned, this is one where screening is available, and they've made it available in the state law. We see payers that still deny for it, and you have to fight and appeal with the Senate bill language. But That's one of the issues that you have there. Overall, California has basically, they're the only state that's done at this point, has extended the PHE, if you will, if you want to think of it that way in your mind, through November of 2023. And they've given a deal that if you don't have a contract, you should be paid at 125% of Medicare during the PHE. The plans must be a governed California Department of Managed Healthcare plan. So what does this mean? This means that your Medicares and your Medicaid, as we talked about earlier, are not necessarily in this. The Medicaid managed care plans are a part of it, but ERISA is not. Now, ERISA was always excluded from the PHE. And ERISA plans, if you guys, just to make sure everybody's aware, are plans that are basically what we consider self-funded. They're large group employers, groups like Amazon, Walmart, Ford Motor Company that do self-insured plans. In California, if you have people who work for Ralph's or Safeway or Bel Air or Rayleigh's, I don't know how many people know all the California grocery stores that are out there, but those employees might be on an ERISA plan. And those plans during the PHE, some of them chose to follow the PHE, some of them didn't have to, and we did see, a very small percentage of them give co-share. It'll be interesting to see what they do in California now, as this has been extended. But I only bring this up because, I want to make sure that everyone realizes just because someone says, I have Aetna, or I have United, or I have Cigna, or I have Humana, or I have a commercial insurance, it doesn't mean that it's not a self-funded or self-employed ERISA group, in which case there may or may not be coverage. And I just caution that because it's really hard. The other thing about California that's fun is, as we mentioned earlier, most of the time, if you go into a state, a major metropolitan area, there are 5 to 15, maybe 12 on average Medicare or Medicaid or managed care plans. In California, it's under the Medi-Cal program. And in most of the regions of California, that's the same. There's somewhere between 3 and 12. When you get to LA area and LA County, there's 480. And it is the only place in the United States like this. And the risk can be delineated between IPAs and MSOs. So if you're not in California, you can kind of shut your brain off at this point and just say, I don't even want to know this. It's too crazy. It's always different out there. If you do operate there, this stuff is very, very important. So you do not have to be a network provider. That was in the law that Governor Newsom signed in. But we do need to watch and see what the payers do. We contacted several of them about this extension into November, and Anthem Blue Cross even said, well, we're not sure we're going to do it. And we're like, well, okay, that'll be a fight down the road. But I know plenty of the labs we have in the California area are planning to continue to move forward, although the volumes are considerably down as they have been. They are planning to move forward. But through November of 2023, in California, things are basically the same. So from that standpoint, the high throughput codes are retired. So the reimbursements changed. It's no longer $100 like it was during the PHE. It's back to that 51, just like Dean said earlier. The collection codes are retired, so that's not an additional source, even though they've extended this. What basically gets extended is no cost share, out of network doesn't matter, and many of the other rules that you went with before, like you could do screening, you could do for COVID testing, and you can for vaccines do it. Now, over the counter is no longer available. That's closed, just like we talked about on every other group. It may be covered, it may not. You have to check at the plan level if you're considering to continue to do that. Antigen and antibody will stay the same. William, Dean, do you guys want to add anything about Hotel California as it is out there?
Well, after November 23rd, for in-network, there's still going to be no patient cost share. After November 23rd, if you're out of network, then they are allowed to have the cost share for the COVID. So that's important. So in and out up until November 23. And this is also applicable to, as Brett said, diagnostic and screening. So it's a wide net.
Awesome. Okay, so now I wanted to get into just a few other things that are not necessarily tied to PHE, but it is what's happening after PHE. So I wanted to, well, where did I put it? Not there. wait, I'm looking at the wrong one. Okay, there we go. Okay. So we had a big change in January of 2023. So it was kind of before PHE, but also after. There were some really, I think, favorable changes, right? We got more money for doing phlebotomy. You get your $2 bump on a sniff as well. So I think it was $3 before. So we got $5 more, and then you always had your $2 bump on a sniff when you're billing a sniff. And so the biggest thing to know is, it's for phlebotomy, for blood collection, and it's for urine catheterization. It's not for collecting a swab sample, for example. The patient should be homebound or a nursing home patient or a non-hospital inpatient. And that's it. It's not for you to go and get paid for collecting blood at a doctor's office, okay? The flat rate travel allowance is $11.10. Now, prior to this, 2023, if the average distance between the patients that you're seeing was less than 20 miles, you would use this flat rate travel allowance. Well, now it's only if you're going 20 miles or less to just one location. As soon as I'm going to multiple locations, I start using the per mile travel allowance. And so when the round trip travel to one location is greater than 20 eligible miles, then you would do that. And then as long as you went to more than one location, you're instantly using the per mile travel allowance. There's a lot more to this. There's about 5 pages worth of red new documentation in the Medicare claims processing manual this year. You do want to talk with a qualified laboratory specific and focused billing company to figure this out for you. Another couple of things that we didn't mention, right? You used to have to start at the lab and end at the lab, which made no sense, right? Your collector is 3 miles away from where they need to go, but they got to come in 50 miles to the lab and then leave 50 miles to go back. That was just stupid. So they said, forget about it. It can start wherever you want. You can end wherever you want, but you want to record it, and they're okay with you doing that through digital means of GPS trackers and that sort of thing to kind of back you up that you did this. And you do want to document it, whether you're writing it down or you're using some kind of a tool to do that for you. You want to document it. But there's a lot to figure out with this, because you also need to track whether there's a Medicare beneficiary there or not. And so if you go to a location without a Medicare beneficiary, those are not eligible miles. And how many Medicare patients, and dividing it only by the Medicare patients. So lots of cool stuff there. You want to work hand in hand with your billing company to make sure that it's going to get coded and billed correctly. They are auditing people on this kind of stuff. And actually through their audits, I think it's why they changed this, because I think, Dean, you had a scenario where somebody was arguing about this, where you started from and ended up at one point, right? And so
Yeah, William and I have gone back for this, and thank goodness that they've changed it. So it'll give us something else to talk about. Very confusing.
Yeah, it was. Okay, so a couple of things. Oh, so we had told you about changes for toxicology. Those are, well, it was going to be that there were only 14 drug classes, and Medicare was playing God or scientist or something, and they decided that there would only be 14 drug classes now. And so then they cut the codes in half. So there was only GO480 and GO481, and the other two were considered non-covered codes. Well, all that's gone now. So it's back to the normal set of drug classes, and you have the same set of diagnostic codes. You can call us for more information on the impact to you and your toxicology testing regarding that.
Yeah, it's gonna be easier to get reimbursed for GO480 and 81. 82 and 83 may take an act of Congress. And then you've also have to look at the commercial carrier level. For a while, a lot of them have said, we're not paying GO483 anymore. We consider that a non-covered service. So you have to look at that's going to be plan specific on the commercial side.
Excellent. And we've pretty much run out of time. One other big thing I just want to lay on you, and you should definitely get to us, and we're probably going to have a separate webinar on it. We do have webinars already on what a Z code is and how to get one, and which ones do you need them for, and who uses Z codes and whatnot. But if you haven't already experienced it, your Medicare Advantage plans are starting to ask you for Z codes now. We can help you with that. UHC in August will require Z codes for commercial plans. What's still under contention is it going to be for everybody, even when you're in network or out of network? We're going to be clarifying some of that, but it looks to me like it is for all commercial plans, wherever you're located, regardless of whether you're in a MolDX MAC or not, just like it is for the Medicare Advantage plans, that you're going to need to have a Z code now, and they're only in the 81,000 series of CPT codes because they release these in waves, and the first wave that we're in uses only the 81,000. So if you're doing PGX or any kind of heavy duty molecular pathology, you're going to need to have that. And of course, if you were using an unspecified code, you're going to need that. And then you can see there's a bunch of PLA codes over here that are going to require it. And I guess the last thing I want to leave you with is infectious disease testing, and Novitas and First Coast has definitely got a provider alert out on coding that properly. So again, you want to talk with a billing company well versed in this.
Yeah, and the stumbling block is those two letters, TA, technical assessment, which is a clinical utility and a clinical validity. That's a very, very high hurdle that most have or have stumbled over.
Yep. Well, Linda, I hadn't seen, well, I did see the one question we had typed in. Are there any other questions?
Let me ask the group, are there any questions for our panel before we close our webinar? Well, I'm not seeing any questions. So for that, this brings us to the end of today's webinar. We'd like to take the opportunity to thank everyone joining us this morning and our panel of experts. Please do take a few minutes of your time to fill out the short survey that it would appear at the end of this webinar. Let us know what you liked about the webinar, how we can improve further, and maybe some other topics that you would like to see. Your feedback is greatly, your suggestions are greatly important to us. As a reminder, a copy of this webinar will be sent out via email in just a few short days. If you have any questions or would like to schedule any additional time with anyone from HRC or with Dean, please let me know. My contact information will be at the end of the email. Again, Linda Protopapis. And with that said, everyone have a wonderful day, and thank you so much for joining again. And thank you, panelists. We appreciate you.